Good morning. My name is Belgica Aroca. Hepatopulmonary syndrome. Definition. Hepatopulmonary syndrome is the most common cause of respiratory insufficiency in patients with chronic liver disease. It is characterized by a gas exchange abnormality caused by intrapulmonary vascular dilatation in patients with liver disease.
Hi, this is Medicosis Perfectionalis. Let's talk about hepatopulmonary syndrome. In a previous video, we have talked about the triad of the hepatopulmonary syndrome. But now let's get more details and more pathophysiology. So, hepatopulmonary. A problem in the liver will lead to a problem in the pulmonary, i.e. lungs. Liver problem leading to lung problem through nitric oxide. But first, let's discuss the normal body response to hypoxia. Any tissue except the lung responds to hypoxia by vasodilatation, i.e., increasing the lumen of the blood vessel. And this makes sense. Why? Because now we will get more blood into the organ, which needs more blood. Now we have hypoxia or less oxygen in the blood. So this is the response in any organ except for the lungs. Why is the lung different? Because in the lung, say we have a problem in this portion of the lung, they vasoconstrict, i.e. they narrow. And why is that? To save the blood for the good portions of the lungs that have normal physiology, that can normally handle the blood. So the normal physiologic response in the lungs to hypoxia is vasoconstriction. However, in hepatopulmonary syndrome, we cannot vasoconstrict in the lung. Why? Due to nitric oxide release from the liver. The liver is cirrhotic or suffer from portal hypertension, releases nitric oxide in the bloodstream, goes into the lung. These blood vessels, so here is the alveoli and the blood vessel. The blood is really flowing quickly from the arterial end to the venous end. So there is no time for gas exchange. So it's a shunt. There's an arteriovenous shunting, and there is no time for gas exchange. This is called shunting. Perfusion is more than the ventilation. So this is shunting, which will lead to less oxygen going back to the heart, less oxygen in the blood, i.e. hypoxemia, decrease in the PO2. So this hypoxemia, of course, will lead to hypoxia. And the response to hypoxia through the kidney producing a hormone called EPO is absolute erythrocytosis. So now we have a symptom called platypnea, which will be discussed later in a different video. But for now, you got the idea behind hepatopulmonary syndrome. I cannot constrict the blood vessels in the lung as I normally do, so there is arteriovenous shunting, hypoxemia, and hypoxia. So it's a good idea to measure what? The oxygen saturation by pulse oximeter. Also, note that these patients with hepatopulmonary syndrome, they get priority in liver transplant, because maybe if we wait so long, it will be permanent and there will be no hope. They give priority. Thank you very much for watching the video. If you like the video, please subscribe. There are new videos coming on the way, so give it a like. See you next video.
Application in nursing. Clinical characteristics of patients with HPS are mainly consequence of hypoxemia. The leading symptoms like cyanosis and digital clubbing. Furthermore, platinoa and orthorexia are observed in up to 25 of the patients with HPS. However, clinicians should be aware that chronic pulmonary comorbidities can coexist in HPS. In particular, chronic obstructive pulmonary disease, bronchial asthma, idiopathic pulmonary fibrosis, and restriction of the lung following extrapulmonary complications like ascites of hepatic hydrothorax can contribute to aggrave dyspnea. As our understanding of the cause of HPS evolves, it is more and more evident that this non-mediated change in pulmonary blood vessel size likely results in a more chronic change in the structure of blood vessel tissue, which is called vascular remodeling. In Suez Applet in Ecuador, lung perfusion scanning determines the extrapulmonary tracer accumulation, but is not able to distinguish between cardiac and intrapulmonary shunting. It is mainly used to distinguish the degree of hypoxemia caused by intrapulmonary vasodilatation. Other potential contributing factors like non-vascular pulmonary or extrapulmonary factors. Lung imaging techniques like chest X-rays of thorax computer topography are useful for excluding other coexisting chronic respiratory conditions.
Hepatopulmonary syndrome. It's a disease in the pulmonary caused by the hepato. So liver disease leading to pulmonary disease. The liver is cirrhotic. Cirrhosis leads to secretion of vasodilator material, cause the blood vessels to dilate. Okay, also this will lead to decreased oxygen going to the lung, leading to hypoxia. This is an oxygen tank and decreased in this patient. Also, you will have something called platypnea orthodeoxia. It's that the patient has dyspnea on sitting down, and this dyspnea may disappear when he lie down back on the bed. So this is called platypnea and orthodeoxia because there is hypoxia in this position. So this position is called platypnea and has hypoxia, so it's called orthodeoxia. So this is the triad of hepatopulmonary syndrome. You have cirrhosis, you have a patient with orthodeoxia or platypnea, and also there is hypoxia. How to diagnose? Contrast echo. Contrast echo, and also you can use technetium albumin. Hepatopulmonary syndrome, cirrhosis, hypoxia, and platypnea. Diagnosed with contrast echo and technetium albumin.
Conclusion. current knowledge about HPS is limited and is essentially based on a study of circuit patent lists of LT or animal experiments. These studies have enabled us to establish the fact that HPS is a frequent complication for the patients, and although it is generally asymptomatic, it does have an impact on their quality of life and survival. It has also been established that LT is an efficient method of treating the syndrome and has positive post-transplantation survival results even in severe cases. Thank you.